Welcome to Nurses
Yay!
Showdown! I'm so excited to have you guys join us today. Welcome. This is the first ever game show for nurses, and I'm super excited that you guys have taken the time to participate in this. I'm your amazing host, Felicia Igbinosa, and joining me today, I have two amazing, seasoned. When I say seasoned, these nurses are seasoned. Seasoned nurses joining me today, and these two nurses represent two different specialties. Okay, I have Jenny representing the ED, and I have Hank representing PCU and a whole bunch of other specialties, because he's been around the block. Okay, he's done it all. He's done it all. But hey, I'm not going to blow too much of your trumpet. I'll let you guys do it all on your own. So I'll have you guys introduce yourself, starting with Hank. Let us know who you are, how long you've been a nurse, and what your nursing specialty is.
Okay, I got out of Corpsman School in 1980 and ended up in, 79, oh my God. 79 up in Iceland. My first thing is I participated in birthing a baby, which turned out to be a C-section, emergency C-section. And I've been doing nursing ever since. So there you go.
Wow, you have birthed babies.
He's much more seasoned than I am.
Yeah.
I wasn't even born yet.
Right?
Yeah.
I wasn't even thought of being born.
Believe me.
Amazing. That's amazing. Thank you so much, Hank, for joining us, and welcome. All right, so over to you, Jennifer. Let us know who you are, how long you've been in specialties.
So my name's Jennifer. I've been a nurse since 2014. I went to nursing school in Arizona, and then I started my career actually up in Montana in a PCU unit, like PCU tele, and did that for 2 years. And then I came back to California and did PCU tele, and then moved down to the ED about 7 years ago now. So I've been ED ever since.
Wow, that's amazing. That is amazing. Welcome, and thank you for joining us today. All right, so a little disclaimer before we go into the rules. This show is meant for entertainment and also for education, okay? But more so entertainment. Now, for those who are watching, please make sure whatever information you get from this show is not used as the basis for your clinical practice. You can use it as a supplemental information, but not your basis for clinical practice. So make sure you are following your hospital protocol, guidelines, and policies, as well as your doctor's orders. So do not use this information as a basis for your clinical practice. Now, with that said, let's talk a little bit about the show, and we'll go into the role. This is the most easiest and fun way to win money. In fact, it's better than overtime. Yep, I said it, you can quote me. It's better than overtime. Now, going into the rules. So this is just a little caveat to make it a little bit more competitive, and just so it's not so easy for you guys, because you guys are seasoned nurses. I can't make it too easy, right? The questions are not going to be limited to your nursing specialties. You're going to get questions from anywhere in nursing, including peds, NICU, case management, dialysis. They're coming from anywhere. Psych. Okay? So, nurses, are you ready to do this?
I'm ready.
All right. Okay. So let's get this show on the road. So Jenny, choose a number between 1 and 10.
9.
9. Okay. Question number 9. A patient presents with sudden palpitations and narrow complex tachycardia at 180 beats per minute. The patient is alert and is hemodynamically stable. Vagal maneuvers were not yet attempted. What is your immediate action as a primary nurse? A. Immediate synchronized cardioversion. B. Attempt vagal maneuvers and prepare for adenosine if needed. C. Tell the patient to call family because you're about to stop their heart. D. A and C. Your 10 seconds starts now. B. Oh, right before the 10 seconds. All right, see? Oh, Lordy, this is going to be way too easy for y'all. Okay, 10 seconds is up and you have both showed me your answer. So, Jenny, why did you choose B?
So we always want to try the least invasive before we go to the most invasive treatment. So vagal maneuvers would be the attempt to try and reduce that heart rate. And if we didn't succeed, then we would move on to something else, such as pharmacological or possibly, shocking the heart.
Okay, very good. Hank, why did you choose B?
Pretty much the same thing. Obviously, if I can, I'll have the charge nurse or somebody make sure the doctor's in contact so I have that order for adenosine, just in case the vagal maneuver doesn't work. Keeping everybody in the loop as well. I mean, obviously, I'm sure that's what she's doing too. But yes, that's the response, least invasive to most invasive.
Okay, very good. Well, let's see if you're both correct. Yes, you are. Attempt vagal maneuvers and prepare for adenosine if needed. Now, here is the reason why we would do that. For stable SVT, initial treatment includes vagal maneuvers and then IV adenosine per ACLS. If maneuvers fail, synchronized cardioversion is reserved for unstable patients. Very good, very good. Okay, Hank, a number between 1 and 10.
1.
Okay, 1. Let's go to 1. Question 1. A 30-week infant, hours after birth develops increased work of breathing and requires FiO2 0.4 on nasal CPAP to maintain saturations. What is your immediate action? A. Continue CPAP and notify neonatologists to consider early surfactant if respiratory support increases. B. Start broad spectrum antibiotics. C. Place infant prone and discontinue CPAP. D. A and B. Your 10 seconds starts now. Okay, what did you choose? Next. Okay, D. Okay. What did you choose? 10 seconds up. C. Okay. All right. Now we're competing now. Okay, Hank, why did you choose C?
I don't know. I'm reading into it, but I'm thinking open the airway first. That's why I'm thinking prone. But you kind of don't have the answers I want. And discontinue the CPAP if it seems to be ineffective. Then I'm thinking I'm probably going to have to suction the child, and then I'll also obviously, if I'm in a NICU environment, I'll be contacting the nurse right next to me to assist. But I don't want to. I want to contact the neonatologist too.
Okay.
I don't know. I don't like these answers.
You don't like the answers?
Beyond these answers, to tell you the truth, I'm thinking airway, contact the neonatologist, and then obviously, I don't see where his SATs are in here. I just see he's increased work of breathing, but he's already on CPAP. So I'm thinking the CPAP's ineffective. Why would I want to continue that?
Okay. All right. Okay.
That's my thinking.
Okay.
My thinking is just open up the airway, try to get his SATs up, do the suction. Obviously, involve the neonatologist and my coworkers. If I'm in a NICU environment, I have other nurses to assist, and then and move along that way.
But your answer is C.
Yeah, C's the closest to that. I don't know.
Okay.
C's, yeah.
All right, Jenny, why did you choose D?
Well, so how I read this question is that they developed increased work of breathing, and they were requiring FiO2, and they're on nasal CPAP to maintain their saturation. So I wouldn't discontinue the CPAP, so I would continue the CPAP, and I would also notify the neonatologist to consider early surfactant to support respiratory, if respiratory support increases. I mean, to some degree, it doesn't have all, just like Hank said, it doesn't have all of the information I need or want in order to answer it appropriately. But I also feel as though starting, a already compromised infant that could possibly have developed some form of respiratory bacteria, possibly start them on broad spectrum antibiotics as well. So that's why I chose D. So my answer is D, both A and B.
Okay. All right, so let's see which one of you is correct. Here is the answer reveal. Your answer is
That's
A.
just A.
Yeah, CPAP. And
Yeah.
I just don't like that. I don't like the surfactant in there until I know what the rest of the situation is.
Yeah.
So I think both of us are just like, we want more information, please.
Right.
Okay, so your answer is A, continue CPAP and notify neonatology to consider early surfactant if respiratory support escalates. Now, here's the reason why we will do this. Preterm RDS is frequently managed initially with non-invasive support such as nasal CPAP. Early selective surfactant administration is indicated for infants with progressive respiratory failure, despite CPAP. Surfactant reduces mortality and air leak syndromes in appropriate infants. Decisions about intubation and surfactant are team-based and should follow unit protocol. So, okay. All right, Hank. Question between, no, that was you. Jenny, question between 1 and 10, minus 1 and 9.
7.
7. Okay. Question number 7 coming right up. Okay. Prior to discharge, the nurse coordinates follow-up for a patient with bipolar disorder, stabilized on lithium. Which lab value would be your main point of focus for discharge planning? A, check last lithium level and renal thyroid labs. B, check last lithium level and white count. C, check last lithium level and arterial blood gas. D, check last lithium level and hemoglobin. Your 10 seconds starts now. Three, two, one. What's your answer? I can't see. Your answer is blurred. It's blurred out.
Mine?
Yeah, yours is. Oh, A. Okay. And what did you choose, Hank? A. Okay. All right. You both chose A. Now, Jenny, why did you choose A?
Well, we're obviously going to check lithium levels for anyone that's on lithium. But I do believe vaguely in my mind somewhere that it does affect renal and thyroid. So that's why I chose it.
Okay.
White blood cell count, I don't know that it necessarily affects it. I don't know why we would check an arterial blood gas, as well as hemoglobin. So A seemed like the most likely choice for us.
Okay. All right. How about you, Hank?
Again, I chose A because it was the best answer, but in my mind, I'm thinking a few of these combined actually make sense because I also think of leukocytosis. But bottom line is renal is, I want to make sure they got good renal function. So I'm going to check both of those, the lithium level and the renal function, just like my cohort answered as well.
Okay.
So yeah, that's the best of the answers. But if I overthink it or think about it, I probably would want to add more than just that lab there.
Just run a panel.
Right? Okay. All right. So let's see if you're both correct. Your answer reveal. Here it is. Yes, you are.
Hey.
Woo! Very good. Very good. All right. Check lithium level and renal/thyroid labs, and here is why. Safe discharge requires medication reconciliation and monitoring labs for lithium. Yes, it does affect the renal and the thyroid function. Okay, Hank, question between 1 and 10.
We'll go with 2 this time.
2. Okay. Okay, question 2. A 28-year-old female has recurrent vomiting in PACU after a laparoscopic surgery and is lethargic with decreased cough and gag reflex. What immediate action would you anticipate? Place in a lateral recovery position, suction as needed, and consider antiemetic and airway protection measures. B, give oral antiemetic and follow her and allow her to sleep. C, sit patient upright and encourage sipping clear liquids. D, B and C. You have 10 seconds. Jenny's brain is on fire. She doesn't even wait for 10 seconds. 3, 2, 1. Watch it. Okay, Hank A and Jenny
A.
A. Okay.
Am I blurry?
Yeah, it's kind of blurred. I think it's because of your background.
Maybe I need to. Oh.
Yeah.
Can you see it better if I put it in front of my face?
Yes, that's better.
Okay. I'll make sure to put it in front of my face.
Okay. All right, Hank, why did you choose A?
Again, I'm looking at all these answers, and the A is the best one, but at the same time, I kind of want to give her the antiemetic right away, but that's not what we have here. It's the best answer is obviously I want to position, I want to keep the airway open. I do want to consider antiemetics. Obviously, I'll probably be giving it to her. And then airway. Always.
Okay.
That's what I'm thinking.
Okay. All right, Jenny, why did you choose A?
I concur. I mean, positioning is key when you have somebody that's vomiting, especially if they're lethargic and, have no cough or gag reflex or decreased. Always have suction available for those type of patients, and antiemetics are key. And then just making sure that their airway is open and having protecting those that protecting the airway.
Okay. All right. Let's see if you're both correct. Here comes your answer reveal. And yes, you're both correct.
Ooh.
All right. Okay. Place in lateral recovery position, suction as needed, and consider anti-emetic and airway protection measures. And here is why we will do this. Recurrent vomiting with depressed airway reflexes increases the risk of aspiration. The lateral recovery position, suctioning of the airway, anti-emetics, and consideration of airway protection, such as continuing intubation, if needed, are appropriate. Oral intake or discharge are unsafe.
Yeah.
Very good, very good. Okay, Jenny.
Let's do 4.
4. Okay, question number 4. All right, question number 4. A neonatal emergency is underway. A code-like situation. Parents are at bedside and visibly distressed. What immediate action would you anticipate? A. Assign a staff, a liaison, to calmly explain to the family what is happening and provide short, honest updates while other staff focuses on the infant. B. Tell the parent to leave bedside while the code continues. C. Ignore the family entirely. D. A and C.
Can you see it?
Yes, I can say it now.
Okay.
Okay, now the 10 seconds is over. All right. So, why did you choose A, Jenny?
Unfortunately, I've been in these situations in the ER, and I think the best action for an adult or infant or pediatric patient is to have people at bedside so they can see all the measures that you're taking on their family member. So that way there's, no thought in their mind that something wasn't done. Obviously, assigning someone that has the knowledge, that's able to explain what's going on to the parents so they have an understanding of everyone's role and what they're doing and everything is key as well. So I would never tell anyone to leave bedside if we were performing a code, and definitely not ignore them entirely. So.
Okay. All right. Very good. How about you, Hank?
Well, unfortunately, since I'm a dinosaur nurse, I actually was present when the policy was just shove the parents out of the way and talk to them later. And so we know now that is not the best practice at Children's Hospital. We actually came to that conclusion where you have the parents in the room during the code so they could see what's going on. And you do have a person with the parents explaining them what is going on so they're not so upset. But yes, that is something that evolved in nursing. Believe it or not, unfortunately, the worst answers here used to be the correct answers.
Wow.
Yeah.
Okay. And this also applies to adults, not just, kids.
Oh, yeah, I know. For all family members, yes.
Okay. All right. Well, let's see if you're both correct. And yes, you both are correct.
We're so smart, Hank.
Yes.
Assign a staff member.
My job.
Assign a staff member to calmly explain to the family what is happening and provide short, honest updates while other staff focus on the infant. And here is the reason why we will do this. During critical events, a designated staff member should support the family with concise, honest updates and reassurance while the clinical team manages the baby. This maintains family-centered care, reduces confusion, and allows clinicians to focus on resuscitation. Privacy and trauma-informed language are essential. Very good. Now, Hank, number between 1 and 10.
Might as well continue down the line. Number 3.
Number 3. Okay.
Very good.
Okay. Number 3. A preterm infant with increasing abdominal distension, gastric residuals, and blood-tinged stool presents with temperature instability and apnea. What immediate action would you anticipate? A. Make NPO, place orogastric tube to decompress, start broad spectrum IV antibiotics, and notify surgical team. B. Continue full feeds and observe. Oh, it's giving me C first. C, B, and C. Let's see what C is. D. Massage abdomen and encourage more feet. You have 10 seconds. Okay. Okay. 3, 2, 1. You both chose A. Okay. Very good. Why did you choose A, Hank?
Well, it's the best answer there, but at the same time, I mean, during the military, I could say, yeah, let's start broad spectrum antibiotics, but I would have to notify the neonatologist, obviously, to do all these wonderful things. But yes, I'd want to make them NPO. I'd want to put in the orogastric tube, decompress. Obviously, I'm thinking of the airway as well, all these other little things that aren't in the answers, but that is the best answer to go with.
Okay. All right. How about you, Jenny?
Yeah, I agree. Obviously, no more feeding for your having a distended abdomen with residuals and whatnot. Yeah, I agree with Hank 100%.
Okay. All right. Let's see if you're both correct. And yes, you are. Ooh, okay. All right. Make NPO, place orogastric tube to decompress, start broad spectrum IV antibiotics, and notify surgical team. And here is why we will do this. Neck. Patient is obviously exhibiting signs of necrotizing enterocolitis. It's called neck. It's a surgical emergency in many cases. Initial management includes stopping entero feeds, putting them NPO, gastric decompression with NG or OG tube, IV broad spectrum antibiotics, fluid support, and early surgical consultation when indicated. Timely recognition and source control are critical. Very good. All right, Jenny?
Let's do 6.
6. Okay. Okay, number 6. An ischemic stroke patient 30 minutes after IV alteplase develops sudden headache, vomiting, and drop in consciousness. Blood pressure is also rising. What immediate action would you anticipate? Call a code blue and call the family. B. Suspect hemorrhagic transformation, stop alteplase infusion, and call stroke team. C. Obtain emergent CT head and manage airway and blood pressure. D. B and C. You have 10 seconds. Three, 2, 1. Okay, Jenny chose C and Hank chose D. Okay, Jenny, why did you choose C?
Well, it's 30 minutes after the transfusion was complete, so it seems like it's already been given, is how I read that. Maybe I don't know. Okay. Anyway, so I would obtain an emergent CT to see if it is hemorrhagic, and then make sure to manage the blood pressure as well as the airway.
Okay. All right. Hank, why did you choose D?
I read it differently. I thought 30 minutes into the alteplase, but now I see after. Well, if they were on the alteplase, I would stop it. I would obviously do a stroke. It would do the CT. So I would just be doing everything to save the patient. But yeah, I was thinking that the bleeding and anyway, that's why I chose BC. Maybe I just read it wrong.
And sometimes I think too, because like being in the ER compared to like on the floor and stuff, stuff happens differently for him than it would for me, right? So it's like I would immediately obviously go and grab someone. You know what I mean? They're there readily available for me, whereas you guys got to get on the phone and whatnot, and we just run them over to CT without even calling them, you know? So it's like that whole process is slightly different depending upon where you're at throughout the hospital. But,
that is true.
You know.
Okay.
But yeah.
Right. Because the call the stroke team is basically getting your CT orders and all of that good stuff.
Right.
Yeah.
Yeah. Whereas I would have an attending if if our stroke team wasn't already down there, put in a new order and we would go over there and see. So yeah.
Okay.
All right, let's see it.
She goes, let's see. Let's see if you're both correct. Here comes the answer reveal. It's D.
Oh, good job.
All right. Woo, hey, good job. Suspect hemorrhagic transformation.
I think we both got it right. I think we both got it right, in all honesty.
Yeah.
Yeah, I mean, you both got it. You both got it right, but you know, the answers are kind of broken into two options.
Right.
Yeah.
You're right.
Yeah. So suspect hemorrhagic transformation, stop autoplase infusion, call up stroke team, and obtain emergency CT. And here is why. You already know why we would do this. Oh, where's my thing not coming up? Oh, there you go. Acute headache, vomiting, and neurologic decline after thrombolysis raise concern for intracranial hemorrhage. Immediate actions include stopping the infusion, urgent neuroimaging, activating the stroke team and neuro team, and preparing supportive measures, including airway and blood pressure control, reversal strategy if needed. All right, so Hank, a number between
5.
1 and 10. 5. Okay, number 5. Okay, question number 5. A dialysis patient suddenly becomes hypotensive and dizzy mid-treatment. What immediate action would you anticipate? A. Stop dialysis and give IV fluids. B. Decrease ultrafiltration rate and place the patient flat. C. Increase dialysate temperature. D. Continue dialysis at the same rate. You have 10 seconds. Three, 2, 1. Okay, you both have your answers up. You both chose A. Okay, Hank, why did you choose A?
Because she's going hypotensive, I want to stop the dialysis right. I've actually had this occur, so unfortunately more than once, and that's how we've handled it. Bolus, stop the IV dialysis, contact the doctor, obviously.
Okay. Make
your patient's airways fine and all that good stuff too. Other things that aren't here that I'm sure we're both thinking about affecting the patient, airway, breathing, all of that good stuff, and immediately go into action.
Okay. All right. How about you, Jenny? Why did you choose A?
Well, obviously with anything where someone is having an adverse reaction to it, you want to stop it. So that was my initial thing. I don't know a ton about like dialysis, so ultrafiltration rate, it just didn't seem like that would make a difference for me. As well as temperature. I mean, I don't think that that's going to affect somebody's blood pressure. And obviously we're not going to continue it. So A was the best one for me.
Okay. All right. Let's see if you're both correct. Answer reveal coming right up. It's actually B.
Oh, imagine that. Yeah, I have no clue about dialysis.
No, that's not true. I disagree with that.
Okay, all right. Tell me why you disagree. Then I'll let you know
Because-
what the rationale is. What the rationale says.
Because we've actually had that happen, and we did stop the dialysis. We did contact a doctor. We did get a bolus going.
Okay.
That's why I'm surprised
was that the first action you took before stopping the dialysis?
Usually, this is how, if you really want to know how it happened. One time I wasn't there, and it was told to me, and the patient died. The other 2 times when I was there, and it wasn't my patient, but I happened to be charged at the time, the dialysis nurse stopped the dialysis, let the nurse know patient was extremely hypotensive. We called the doctor, we got the full bolus, and that's how it happened. Nothing about decreasing the ultrafiltration rate and placed the patient flat. I'm sorry, that's not how it was responded to.
Okay, all right.
So that's the problem.
Let's find out what the rationale says. Hypotension during dialysis is common due to fluid shifts. The correct response is to decrease the ultrafiltration rate and place the patient flat and reassess. Now, that would be the first initial action you do. Obviously, the dialysis nurse would not tell you the first thing they do, right? When they start noticing.
I didn't know that. They probably,
yeah. So when they notice it, they'll decrease the ultrafiltration rate. Now, if that doesn't work and hypotension persists and patient continues to become dizzy, then at that point you can consider stopping the dialysis and giving IV fluids.
And that's where my role came in, and so that's why I only know that is the answer. I don't know about this other part because I'm not a dialysis nurse myself.
Yeah, exactly.
So my correct answer would still be correct. I hate to say it because when I'm coming into play, that's where I would be.
Well, that's why you're not a dialysis nurse, Hank.
Well, I need to have that education.
All right. Okay. So, who was it the last time? Was it Jenny? No, it was Hank.
No, it was Hank. I think so. That was 5, right? Yeah.
Yeah.
Let's do 10.
Question 10. Okay.
Well, we learned something new today, Hank.
Right?
Yeah, but still. Once it's presented to me, obviously I'd have to go to what my correct answer would be because the dialysis nurse should have done her job already or his job.
I mean, I like I said, my knowledge base on dialysis is very limited. So
yeah, same here.
That's interesting to know that would be the first action. But I guess, I mean, you wouldn't, if you think about it, you wouldn't want to just completely stop it, I guess. And you do expect some form of shift, but
yeah.
Yeah, I mean, there's a decrease in blood pressure, but that's the other part. How hypotensive is that patient?
Right.
Is it critical?
We need numbers, Felicia.
We're nurses.
I need a systolic blood pressure, okay? How hypotensive are we? All right, sorry, go ahead.
All right, question 10. A woman attempting a trial of labor after cesarean experiences sudden severe abdominal pain and prolonged fetal bradycardia. What is the nurse's priority action? A. Prepare for immediate emergency cesarean delivery and call for the surgical team. B. Encourage ambulation and rest. C. Administer oral analgesics. D. A and C. You have 10 seconds.
I mean,
3, 2, 1. Show your answers, okay? A. What did you choose, Hank? Your 10 seconds is way over. D. Okay.
Yeah, I mean, it's probably D, but since she's going to be going to surgery, that's what I was thinking. Probably don't want to give her anything oral just in case they have an issue. But
I know. I saw that too. It's like, God, administer. I don't know.
you're probably
more
right because you
information.
want to do something. You want to treat something for the pain, but I honestly, I don't know that we want. Well, she says severe abdominal pain, so maybe oral analgesics isn't going to be it. They're going to give her something in her IV.
Right, it's
So
gonna have
let's
to
see.
be IV. I know.
Yeah.
I just saw the analgesics, and I'm thinking, God, she's in pain, and then I have this other issue going on.
Right.
Man.
All right. This is inducing some clinical discussion here.
Yeah.
Let's go to the bedside.
Well, because I thought about doing D, and I was like, yeah, but you know, I don't know. Let's see. I could be wrong.
The same thing with the oral. I'm thinking, I don't know, but I don't.
Okay.
I'd rather do it IV too.
Okay. All right. So Jenny chose A and you chose D. Let's see which one of you is correct.
All right.
Most likely.
It's A.
Okay.
All right. Prepare for immediate emergency cesarean delivery and call for the surgical team. Patient is having uterine rupture. Reason. Signs of uterine rupture include severe abdominal pain, loss of fetal station, the fetal distress, prolonged bradycardia, that's a sign of fetal distress. This is an obstetric emergency requiring immediate operative intervention, which is the cesarean, and massive hemorrhagic or hemorrhage preparedness. Okay, so the last question we have is 8. So that would be you, Hank.
Okay.
All right. 8. This side of it. Okay. A 68-year-old metastatic, let me close it. A 68-year-old with metastatic prostate cancer presents with 48 hours of progressive bilateral lower extremity weakness, numbness, and new urinary retention. He reports severe midline thoracic back pain, worse at night. Neurologic exam shows decreased strength, 2 out of 5 in both legs, and diminished deep tendon reflexes. What immediate action would you anticipate? A. Administer pain medication and schedule for physical therapy. B. Urgent MRI of the spine and notify neurosurgery for possible decompression. C. Notify neurosurgery for possible decompression. D. A and C. You have 10 seconds. Okay. Okay. All right. 3, 2, 1. You both have your answers up. You both chose B. Hank, why did you choose B? You're muted again.
Obviously, because I'd want the MRI for the neurosurgery team to be ready to do their thing. And I'm also thinking, do I need to put in a Foley in this guy? But that's not part of the answers. Again, I'm overthinking all of this stuff.
You want to do total care, Hank.
All right.
Yeah, I know. I'm just looking straight down the line. IV access to airway, the whole thing.
Right.
Oh, Lord. Okay.
I'm sure you are too. Yeah. Let me IV in and get an EKG right away.
Right. All the things.
Okay. Why did you choose B, Jenny?
Yeah, I mean, most likely it's metastatic, so it's probably in his bone, and ultimately that's what's causing the extremity weakness and the urinary retention at this point. So MRI would be the likely answer there, and then have neurosurgery evaluate the patient after that.
Okay. Very good. Let's see if you're both correct. Yes, you both are. Woo-hoo! urgent MRI of the spine and notify neurosurgery for possible decompression. And here is why we would do that. Progressive neurologic deficit with back pain in a cancer patient suggests spinal cord decompression. Urgent MRI and neurosurgical evaluation for decompression are required to prevent permanent paralysis. Outpatient imaging risk irreversible loss of function. All right, so we have gone through all 10 questions and you are both tied.
Oh.
Let's see, one. Yeah, you are both tied.
All right.
So we have a tiebreaker question.
All right.
Okay, let's break this tie.
What happens if we both get this right?
Well,
Yeah.
Just keep going until one of us gets it wrong?
huh?
Do you just keep giving us questions until one of us gets it wrong?
No, I'll give you guys a question that may be hard enough to
break the tie.
Yeah.
All right.
So let's see. Okay. A physician's order conflicts with the patient's advance directive. Do not resuscitate. How should the nurse proceed? A. Follow the physician's order regardless of the advance directive, I mean. B. Immediately refuse the order, document refusal, and notify the physician and appropriate leadership or risk management. C. Ask the patient to change the advance directive to match the order. D. Ignore both the order and the directive until someone tells you what to do. See, I told you. Okay, so you both chose B. Hey, why did you choose B?
Well, as I'm always telling all my nurses, we are patient advocates first, not doctor advocates. So I always advocate for what the patient wants first. And obviously this patient doesn't want to have CPR. So therefore, that's my first thought. Obviously, everything else in that answer is correct too. Document it, inform the MD why I'm going to refuse his order, and then take it up to the chain of command. I'll be contacting you, Felicia. And and we will hash this out. But unfortunately, as you already know, Felicia, I'm sure this has happened a few times.
Yeah. Okay. How about you, Jenny?
Yeah, same thing. I mean, we're our best patient advocates, especially in times of need when they can't advocate for themselves. So, you know, if that's what their wishes are, we need to do our best to give them, you know, what they want. So,
okay, I have a follow-up question. So now, if you encounter a doctor who gets a little too attached to the situation and to the patient, right? And there's already an advance directive in place. The doctor is aware of this. And this patient is coding, and the patient gets so emotional and gets so attached that he jumps in there and starts chest compression, knowing what the patient has already instructed. Would you jump in there with the doctor and assist him?
no.
Okay. All right. So you just let the doctor continue, or would you tell him to stop or call security to get him out?
I would probably tell him to stop. I don't know. I have a hard time holding my tongue. So ultimately, I'm very outspoken, and we've actually had patients come in that, unfortunately, in the field before it was found out that they were, you know, DNR, DNI, they performed ACLS measures and full resuscitation on these patients, and then they come in and, you know, we've intubated them and everything, and, you know, family is called and is like, oh, they were a DNR, you know, DNI, and you're just like, oh my gosh, what did we just do to this poor patient, you know, like, but those things need to be readily available. I think that's also another issue is that, you know, people do have wishes and, you know, things documented appropriately. It's just a matter of, you know, especially, you know, out in the field. And then when they get to us, unless we have that information readily at hand, we're going to do whatever's necessary for the patient. So,
yeah. Okay, very good. All right, let's see what the answer reveal says. Yes, you're both correct. I think we need to keep going.
Yeah, I know. I was like,
we could do this forever. I'm sure.
I know, right? We good. We'll have to come back on. You know what we'll have to do? Felicia, we'll have to come back on, Hank and I, and have like a whole nother round to like have an official like tiebreaker.
Right?
You know what I mean?
We'll have to go by time wise. First one answer up.
Yeah.
Okay. All right, so here is the rationale for this. Advance directive represents the patient's legal instruction. Nurse should follow them, and if a clinician's order conflicts, document the refusal, notify the physician, and involve leadership or legal/risk resources. Option A undermines patient's autonomy. Option C is inappropriate in an acute setting. I think in any setting actually. And option D is just purely unsafe. And yes, you're both right. We are not doctors advocate. We are patients advocate. And I mean, we've seen a lot of situations where we have patients without legal representation, and this patient is unable to speak for themselves, no family to contact, and you have critical decision to make, more like a life or death situation. It's not a cold situation just yet, but it's getting there. You know, prognosis is bad. Then that's when we get the ethics involved, and you know, they're making decisions that may or may not even be along the line of what the patient wants. But again, we don't know. And just like Jenny says, we'll do whatever we can for the patient until whatever it is we're doing is no longer beneficial for the patient. At that point, then we'll make a decision whether or not, hey, let's, you know, put the patient on comfort measure and just let things be, or keep going. So, you know, we are placed in very difficult situations a lot of times, more so than not. All right. This is very, very good. Thank you guys so much. And yes, you both tied, and we're not gonna keep going. Maybe we need to have another round. We need to have another round with you guys, and maybe with some more difficult and some more thought-provoking and critical thinking inducing questions, you know, to find out who the winner is. So who gets the street cred?
That's right.
Who gets the street cred? All right, so you both have $90 based on your points and your winnings. So yes, this will be sent to you, and thanks to Gemsy Scrubs, you both get a pair of Gemsy Scrubs.
Oh, nice.
Yes.
Oh, we're excited.
I know. Gemsy is sponsoring this show, and we are so grateful to them. And yes, you are both going to get a pair of Gemsy Scrubs. So please send me your sizes, and whichever one you want, you can go on the website. It's called, the website is www.gemsymart.com. Look through what we have there and choose whichever one you want. www.gemsymart.com and choose whichever one you want, and let us know what your size is, and yes, you'll be getting that. Thanks to Gemsy. Okay.
Thank you, Felicia.
You're welcome. You're welcome. And this concludes the episode, and you have been able to display your level of, you know, critical thinking. I'm sure I know there's a lot more there, but I just didn't have enough hard question to pull it out. But don't worry, I got you.
I don't want to be tricked up. Trust me, you're fine.
I got you. I'll come up with some more harder questions, you know, to make you guys really, really think. This was too easy for you guys. Okay. Alrighty, thank you guys so much.
Thank you, Felicia.
Thanks the audience for watching, and have a good day.
Bye,
You too.
Hank. Thank you.
Bye.
Bye.
Bye-bye.
Bye.
Bye.